So today we have the Washington Department of Corrections Chief of Dentistry. Dr. Richard Murphy spent 2 years in the Naval Dental Corps. He worked private practice for 10 years, and now he served 30 years. 30 years in the correctional dental care as a clinical provider, and currently as Chief of Dentistry for the Washington Department of Corrections. So please welcome Dr. Richard Murphy.
Well, in my alter ego, I'm Pat Murphy. I would say my mother probably was not in the correct state when I was born, and so she got it mixed up. So anyway, you'll find me somewhere under Pat Murphy as opposed to Richard. Now today we're going to talk a little bit about homelessness as it relates to the prison system, at least our prison system. I think you need to understand that it kind of works both ways. People get in a jam with the law, and they could be homeless, and then they can't support themselves, so they go out and commit a crime, and maybe the first time they get away with it, but the second time when they're picked up, they enter the judicial system. And then the other way is that they end up homeless as a result of going to prison. When an individual gets thrown into the prison, they get out and they can't find a job. I mean, that's just well known. And so you have it being one of these things where it works both ways. One doesn't just cause the other. They both cause each other. That's the way to put it. So let's move along a little bit here. I just wanted to show you some of our facilities, because I'm going to urge you to think about working for us in the end. This is the place they come into. This is over in Shelton, and when they come in, we do a comprehensive dental examination on a mental exam and medical. And so we try to identify their severe needs along with some of the routine needs that they have, so that when they go out to their facility of assignment, we can address those as immediately as we can. One of the things that we've developed is a D3 protocol. We identify those individuals that come into the system with infection, broken teeth, severe abscesses. They're real identifiable, and then the others we pick up on panographic radiographs. The decay that they have, we address the most serious of it. We can't do everything. That's totally impossible. So we address the worst of the conditions when they get into their facility of assignment. We have a 90-day time span over which we expect them to be seen and treated. And the D3 protocol I may talk about a little bit more, but I would just say that it was the result of some brainstorming between me and one of our oral surgeons / MDs. We don't have enough dentists. The legislature doesn't fund dentistry in corrections very well. And so with the vast number of problems that these individuals come in with, we have to come up with some strategy that's going to work. Mainly, what we're doing is trying to address their immediate needs when they come in, so we can batch the work. Instead of being nickel and dime, some guy comes in first thing in the morning, I've got an emergency. Okay, he does it 3 times. You're burning quite a bit of time each time this individual comes in. So what you really want to do is take the pathology, try to batch it to where you can sit down in 1 hour, hour and a half appointment and knock it out. And we have noticed a difference. It's been going now for about 3 years. When we do something like that, the results are slow to occur, because you've got to consider, they get out, they come back. Well, if we take care of most of the pathology when they first come in, then when they get out, they're going to come back to us as recidivists, and 65% of them do. Then the pathology is not as great that we have to deal with the second time out. This is the same facility, just less pixelated. This is a fairly large facility. They have some people that live there, but the intakes, they do 40 a day. They get 42 offenders a day. We have a population in the prison itself of between 16 and 17,000. However, we get another 7,000 every year. So 7,000 get out, they're backfilled with another 7,000. So in actuality, we are responsible for 24,000 offenders annually. We have 18 clinical dentist positions right now. So it's fairly overwhelming in some respects. This is another nicely pixelated picture. These that are pixelated, they come off our own website, so go figure. That's a coyote there in the middle of this sign. You'll notice how flat it is. This one's north of Pasco. Wind blows like the devil up there. And you'll notice this is what a modern prison looks like. Coyote Ridge is probably one of our newest. You'll notice the structures here. They separate offenders by their likelihood to be violent. Okay? And that's why you have these individual modules. In the older prisons, it was just a big blockhouse. Everybody was mixed together. Not so good if you were being predated upon. So these are much better for everyone, safer as well. You'll notice the black rock around it. With our eco-consciousness these days, they didn't want to put grass there because they don't want to use water because there's not much water there. So this is like black volcanic rock. This is what that place looked like. This is our newest facility, by the way. And it looks that way. You've got modern construction, and you can see the volcanic rock over here on the side. Hold on a second. Let's see if I can get there yet. Yeah. Down here at the bottom, you'll see the volcanic rock. You won't find a stitch of grass at this place in the facility. This is our oldest. This was a territorial prison back when it was Northwest Territory. They say it started construction on about 1886. This facility, as you can see, you've got your old guard tower, but these are original rock walls here. However, if you look on the inside of it, not many of you really want to see the inside of the place. We have concrete walls built, and some of the original red brick have been reinforced with the concrete. And you'll see the more current type of guard tower that's there. And this well-pixelated picture shows you what the facility is. Washington State Penitentiary, of course, and it's in Walla Walla. And I swear, when you walk through this facility, you would believe you are in a Boeing plant. It's big business. I think this probably supports all of Walla Walla. We have 8 major facilities located where you see them. I have my office in Monroe. In Monroe, we actually have 5 different correctional facilities all aggregated together. And then we have 4 camps that are more remotely located. These are camps where DNR is supported by the low security offenders. So we have some, like at Battleground, weapons and stuff in there. And so when there's forest fires, these guys are called out and they help to protect the state. Offenders in prison, as I said, between 16 and 17,000. The numbers vary. It does have a little bit to do with the amount of funding we get from the legislature. And you'll notice on work release, we have a couple of facilities that work release, and we've got 700 out there. We don't use many Redo beds anymore. They just got too expensive for us. Males, about 92%, females about 7.5%. There's 30 years ago, I was told by someone who had been working in corrections a very long time, you have to do something horrible to get thrown into prison as a woman. juries are just reluctant to send women to prison. So that's why you see this disparity in numbers. There's your racial breakdown. 60% of ours are white. When I worked in the Texas prison system, the numbers were quite different. We had many African Americans that were in our facility, many more by percentage. And the number, it doesn't show it in this slide, but we have a lot of Hispanics in there now. The number keeps growing as they move into this state. So, as I put this together, I mean, I had some preconceptions, shall we say. Having been asked to do this, I had to do a little research on it. And I came to the conclusion that, by and large, we need to rethink homelessness. And it impacts us in the prison system, but it is prevalent throughout the nation. There's a couple of different kinds. There's those that are economically homeless, and there are those that are chronically homeless. Since 2007, the number of homeless has increased significantly. The bandits of Wall Street brought many people to their knees. What you really have are people that have lost their jobs. Some of these people having children, so you find the children on the street along with them. There's not quite enough money to go around to take care of the social services that need to be applied to the problem. In this state, every department is vying for more money, a bigger department. They have justification for it. When you get to the homeless, though, it's a hard sell. It's like homelessness pretty much traps these people in their situation. Think about it for a moment. Let's say you're going to look for a job. Would you go to look for a job looking like you've been wallowing in mud? And if you did, would you expect to get hired? When these people are homeless, you know, they can't do what you and I do every day when we get up. You know, they can't look the part of a working person. Many of them have terrible teeth, related back to dentistry. When they're on the street, it's neglect. Some of them have a long history of drug use. Methamphetamine is being very prevalent on the streets. It's a little less now, but it's still coming up from Mexico. Last time I heard, Mexico was the largest user or importer of pseudoephedrine. Of course, that's been used as a precursor for methamphetamine for quite a while. So they busted most of the labs in the Midwest, and some of those still exist, of course. But we see meth mouth very often in the prison setting. And many of these people come in and they, they've been homeless for a very long time and they've never gotten any of it treated. Lots of infection. Some of the causes of homelessness, I'll let you read the slide yourself, but let's just say laziness and misfortune can definitely lead to homelessness, but it's not your primary reason. And for most of us who haven't grown up around homelessness, we probably think the first one is a major reason for it. It's just, we don't know. Other causes, as I say, heavy and hard drug use. I mean, we're talking about daily use of a lot of this stuff. We see, like over there where my office is located, it's a special offenders unit, and it's a place where we have those that are psychiatrically challenged. I look at some of the mental health components of the health record. Seems to be a common thread through there for those that are young and they kind of lost their wits. They've done a whole bunch of hallucinogens and a fair amount of methamphetamine. And I assume that it pushes some of them that are borderline over the edge, and others that probably would have gotten along in life fine. Before doing that, they have a problem with trying to discern reality. Which, of course, is a nice combination for getting you in prison or, sideways with the law. And of course, one of the big things, like most of us in here, if you got in a jam, you probably call mom, dad, and uncles, somebody, brothers. Say, look, man, I'm in jam. Can you help me out? Well, most of these people can't do that. And they may have relatives, but if they've been on the street a while, they've had a drug habit, they just wash, the family washes their hands of it. So they're, they just don't have any way of getting out of it as we talked about. I'm not going to dwell on this. I'm not a preacher, so I'll just flash through these pretty quickly. I did like this one. The guy on the right, you'll see on some of the television shows, mostly tech shows, if I remember correctly. I like this because you could just as easily put an equal sign between these two. If you're homeless, you're jobless. And if you're jobless, you are going to be homeless. Just a matter of time. Oops, go back here. This fellow's on the street. You ever notice how the dogs are highly sentient? If you haven't learned about that yet, I think they would have inherited the earth if they had hands. But they're also very good judges of people. And you get some kid like this. Let's just say that the guy grew up on the streets. He was homeless and been homeless for years. Now, if he wants to support himself, what does he have to do? Well, he has to do something illegal for the most part. And so they're going to come see us when they do this. If the social services had been there originally to help this guy, his family, and so forth, he might have had, a future much like our own. Psychiatrically challenged individuals. It's so easy for them to get in the Department of Corrections. We don't have any social services. We let all of them out on the street because we said the facilities that we kept them in were horrible. So now they walk the streets and get in trouble. They don't have any kind of structured environment. That's one thing that the prisons provide, a structured environment. We assure that they're going to get their psychiatric medications. Most of these guys get out on the street and they start thinking, oh, I'm feeling better. I don't need to take that medication. Before long, their schizophrenia unmasks itself. And they get in trouble. They're picked up by the police. You can get picked up a couple of, and the reason I put this in, like I said, I'm not a preacher here, but this kid, if he's born into homelessness, what chance does he have to become us? And this is kind of the way we handle it. And I don't know all of the reasons why, but I think because it can become too personal. And maybe in the back of our minds we think there for the grace of God or the universe, so we. So that's probably very true. Just imagine when the genes started coming together originally, the evolution of man, it wouldn't take very much for your genes not to be in you, but to be in some of these cases. It's a crapshoot in life, genetic crapshoot. Some of these people just, they just didn't get a winning number. How's it related to prison incarceration? Well, you see that some of these things that they might do to support themselves would get them thrown into the prison or the jail. Repeat offenders will end up in the prison after a while. Just stop throwing them in county or the city jail and start sending them out to prison. As you'll notice, I put something down here about street robberies and drug dealers. Very little thing. How are they going to deal with drugs? They can't even go to a wholesaler and plunk down the money to buy the drugs to begin with to sell. So it doesn't happen very much. And what happens to the homeless children? And so you can read through these as easily as I can. But you can see where it's a recipe for developing abnormal behavior in criminal offenders. And as I said just a moment ago, the criminal behavior, especially if you're a repeat offender, pretty much predisposes you to find your way into a prison. Now, in our prisons, and one of the reasons I showed you a couple of different prisons, I showed you both ends of the spectrum. The newer prison will cost you about $25,000 a year to keep one offender in there. The older prison, the oldest one that we have, costs close to $40,000 a year. So, mind you, we're talking about 7,000 new ones coming in every year. Start multiplying that by these kind of numbers, and those are funds that we could easily use for some of our social services. And, you know, have more productive citizens in the long run than a jail record. I threw this in because I think it's a surrogate for what's happening in the United States. We don't put much money. Let me define what you're saying. You probably can read it. The brown or mauve or whatever you want to call it is total social service expenditures, and the blue is health services, healthcare services. We're looking at expenditures as a percentage of GDP. And if you notice, we put out about as much social service as does Chile down here. So when I say it's a surrogate, look at the difference in the amount of expenditure we have for health care. I would like to see it slide to where the social services funding was a far, far greater part of that graph, which would draw down things like the health care costs and many of the costs that we incur in our prison system. So this is just a surrogate. I couldn't even find anything in there about percentage of homelessness relative to expenditures for social services. I found that very unusual because it seems like something somebody would have studied. And, you know, as we are talking about here, if you don't fund the social services, then you end up with the other problems that are here. None of these things are good for people. They predispose them to come visit us in the prisons. It also causes some very antisocial behavior. We see some people that are very antisocial. They've just been kicked around a lot, and just like a good dog, you kick them enough, and they're going to be bad. So that's what happens. Okay. So how can we, as dental health care providers, be part of the solution? Now, none of you sitting in here, I bet, are thinking, well, I want to go work in a prison. I mean, I didn't. So, things you can do: you can donate your time to the healthcare provider. There are several avenues for that. You can support logical, doable, and affordable approaches to remediation of homelessness. And, or you can work for entities that provide healthcare services for the underserved. Now that issue is kind of in your hands, whether you decide you want to do that. I'm going to say some things that, in a minute, about private practice, and I'm sure that's your paradigm. Now, the ways that you can help, provide services through state and local jails and prisons, work at DSHS facilities such as state mental hospitals. They have a hard time finding dentists at one of those facilities. Or Medicaid funding, funded healthcare facilities. And much better funding is necessary in order to deal with the neglect that we have. If you haven't heard, Washington State reimburses dentists at 24 cents on the dollar. It's pretty hard to get a dentist to work on many of these patients in need when they're not even being paid enough to flip on the lights and call in an assistant. So we do have some facilities that are, I'm probably being unfair, but I'll just call them widget factories. You see them out on the east side of the state. They specifically cater to Medicaid, and they get a kid in a chair, put him under nitrous, and I mean it's enamel's flying. They badge their work. So the other one that you have is working for the U.S. National Health Service. They also take care of the prisons, and they work in some of the welfare services that are out there nationally based. can you help the underserved population incarcerated in our prisons? Could make a career, working for a correctional facility as a healthcare provider, working for the Fed, or working for a state. I would say that Washington State can sure use you. Washington State is probably one of the most progressive prison systems that you'll find in the country. If offenders are treated like dogs, they will act that way. So we try to do something different. We try to treat them like human beings, provide for them. Maybe when they come out of prison, they won't have the attitudes of somebody who's been kicked around a lot, and maybe they'll change their ways. We also try to do rehabilitation. We provide psychiatric medications. We do mental counseling. You could work part-time for a county or jail, as a healthcare provider. They pay fairly well. You go in 1 or 2 days a week and provide that service. And kind of a big one for us is specialists. Having specialists accept our patients becomes difficult sometimes. Like oral surgeons, I've got to go out and con them into working for us. And once they start doing that, they like what we're doing. They like having our patients there. They just compensate their practice. They see somebody first thing in the morning before the regular patients come in, or the last patient in the evening before they go home. And so it doesn't interrupt their practice. So those of you that want to pursue specialties, I would urge you to think about, accepting these people into your practice. Someone will come along at some point and say, would you take our patients? So it's a safe. When they come to see you, they're going to be assisted by 2 custody officers who come in an orange bunny suit. They've got chains on. We don't let them act out when they're out in the field. So most of these people also, they're very aware when somebody is helping them. Many of them have never had that help before, or anybody caring for them. So they are going to, by and large, be much more grateful than Mrs. Jones that comes into your office and wants, 4 anterior teeth crowned. These people aren't going to worry about, the central incisors are a millimeter too long. No, they will thank you endlessly almost, because you got them out of pain. As far as the specialist is concerned, the same thing occurs. Many of them have been packing around infection and pain for a long number of years. And so when they come to see us, we're the only person that can give relief. And I joke sometimes that we're also the only ones in the system, in the prisons, that have sharp things in their drawers, so why would you mess with somebody that's getting ready to use those on you? But in fact, and in all seriousness, they are very grateful, and they want you to work on them. They want you to help them. Some of the myths associated with working in our environment. You remember what was Paul Newman, Cool Hand Luke, the saying in there where what we have here is a failure to communicate. Yeah, everybody knows that. So no, we're not like that at all. I mean, it's kinder than you would ever believe, unless you work in there. Very dedicated people work in our prisons, both in healthcare and the custody officers. Offenders are ungrateful patients. I just addressed that. It's an unsafe environment, and not so at all. We have custody officers that are outside each one of our dental clinics and in our infirmaries. If something goes down, one of our dentists or physicians or whatever just simply says, okay, we're done, and start arguing with you, okay, we're done. And the custody officer just escorts them out the door. You don't have to put up with any of that stuff. And there aren't many of them that argue with you. The ones that argue with you are the ones that have been on the street a long time. They're well practiced at arguing. I imagine none of you are. So why would you want to go there with them? So the equipment is subpar. A couple of years ago, we picked up surgical handpieces, the electrical variety, for instance, from NSK. We use those for our oral surgery. We just went into digital radiography a couple of years back. Everyone that goes through that Washington Corrections Center, they get a pano and a comprehensive exam when they go through there. We share that information throughout the system. And things like, well, you're not going to have any good dental assistants working in it, and that could be further from the case. We pay better than most anyone for our dental assistants, primarily to get good ones to come work for us. So you have either one or two assistants when you work in a prison environment. So our movements are fairly strict. We'll have movements in the morning. Like I said, it's a controlled atmosphere. Movements in the morning where they can go to their appointments, movements in the afternoon. During those windows, when you have movements, that's when you jump on the work. You use all your dental assistants. They don't do anything clerical or otherwise. You try to get as much work done on them as you can. And then, you do your clerical stuff or sterilization, whatever it happens to be, during the down times when they can't move. But our assistants are very good. And I would say that they are, psychologically well adapted to dealing with this population, and they are also very receptive of the people that come in the door. The longer they work there, the more that is the case. And all felons aren't dangerous. Some guy's driving down the road. Well, this is more like 10 years ago, let's say. Driving down the road, he's got 5 pounds of marijuana in his trunk. He gets popped by the cops. He gets thrown into prison. How dangerous is that guy going to be? Not much. The ones that are really dangerous, we have those in segregation units or intensive management because they're a danger to the general population. They are a danger to the inmates. So, we keep those separated. So, all of them aren't dangerous and only a few of them really are. The guy that steals cars isn't going to be much of a problem as far as violence. And then dentists providing quality care do not work in prisons. And we have very dedicated dentists who work very hard to provide quality care under circumstances which require a lot of patience. They're dealing with some tough cases. They have limited materials. We don't do cast-crowns. We don't do posterior endodontics. We have a limited amount of resource. So when they come in to be treated, we look at it, even with our policies, we look at it as though it was more like a mission going to South America. Just think, when you go down there to South America, you have to deal with some of these people that come in, their faces swollen, they've got open pulse chambers and so forth. Are you going to worry about doing endo on that tooth when you've got a group of villagers running down the street and around the corner that are begging to get in to see you? No. And that level of care is what they need. We're not looking for incipient caries. I mean, some of our facilities are well staffed enough, and we have individuals in them that are not as bad off dentally. But by and large, we have some pretty bad cases. I mean, many of them, they're just neglected. They look like they have meth mouth. Okay.
So is most of the dental care extractions?
Much of it is. Much of it is. There's not much you can do with it. You see like maxillary molars that are split into the furcation. With the panographic radiographs, where you take that and look at it, periapical lesions around 80% of the molars, just because of that's really broken down. What we do in the Washington Department of Corrections is provide medically necessary dental care. Does anybody use that term here? I wouldn't think so, because until it fell on my doorstep, I hadn't heard of it either as applied to dentistry. It requires the mindset of saying, what is absolutely necessary to provide these people, given the fact that you have limited resources? What's the biggest bang for your buck? Multiple dentists in most of our dental clinics, that's nice. You got a colleague. private practice, you go out here, and if you're a single practitioner, you're all alone. Nobody to watch the store when you're out. Nobody to talk to about cases. Now, we have dental hygienists in most of our facilities, so the dentists, for the most part, don't have to provide hygiene care. We meet stringent, statutorily required dental clinic standards. We have annual DOH inspections, and I mean, they're tough. So we want to run a good operation. And we provide levels of dental care consistent with the statutory requirements of the 8th Amendment. Now, I just had an aha moment a couple of years back. 8th Amendment guarantees that people incarcerated have a certain level of dental care. It's been decided by the federal courts. Those that are homeless, those that are impoverished, they have no 8th Amendment. Nothing to protect them at all. So that's why we do try to provide good care for these people. I mean, we don't want to get under federal court order, that we're not providing adequate care. Very costly, and the courts don't just stop there, they look at everything. Let's see, that was something. Nope. Okay, what do we have in our system? We have interaction with other dedicated healthcare providers in all of our infirmaries. You have a question about a patient's medical condition, you walk across the hall and you can talk with their PA or their physician. Just walk across the hall. No phone calls, no phone tag. If one of them comes in and you notice that there is an undiagnosed mental condition, walk across the hall again. Talk to the psychiatrist or psychologist and get them in. Try to get them some treatment. All of the people that we have working in there are dedicated individuals that are trying to help these folks. Anyone who's not, we call them out. We don't need them. And I had a couple that I've had to fire. They just thought they could just go in there, give them an through the block, it's a boom, and start drilling them. They're hopping around, and I won't tolerate it. I'll kick them out of the system immediately. An opportunity for dentists to develop and refine treatment skills. When you come out of school, you know how to do some things, but you just, you really don't know. There's only more than one way to do a lot of things. Here and there, you can experiment a little bit. You do your reading and decide you're going to approach a case in a little bit different manner. It gives you a chance to build your skills. We have humane patient care. In DOC long enough, we'll replace essential dentition with removable prosthetics. One of the things that prosthetics can do is improve their appearance, and we haven't had monies for that for about 9 years now. And it's like re-entry money is what they would call it, where we make anterior partial dentures so that they're presentable enough to go out and look for a job and not be turned down just because they're unacceptable in appearance. And it's an opportunity to improve the overall health of the underserved population. When working in our systems, every facility, infirmary has custody officer, at least one, providing surveillance. Every employee is responsible for every other employee. About 16 patients a day is what you'll see because of movements, and you have 1 or 2 dental assistants. Offenders in segregation or under intensive management are brought into the clinic, as I talked about, 2 custody officers. They're in chains. Even if they're dodgy as far as behavior, well, those won't even be brought to you. But they try to assure that you're safe. We provide medically necessary dental care, primarily oral surgery, hygiene, restorative, anterior endodontics, treatment of oral pathology, movable prosthetics, and the D3 protocol. D3 protocol I addressed earlier. We use dentures. We expect you to do higher level procedures, not like dentures. We utilize modern equipment, instruments, digital radiography. We have care review committee that determines whether they're going to go to oral surgery in the community and whether we're going to make them prosthetics, because sometimes there are reasons to make them prosthetics besides missing essential dentition, like they have radiation through the esophagus for cancer. And we have access to ancillary radiographic studies and limited blood tests. Our infirmaries are such that if you suspect that somebody's got a fractured mandible for whatever reason they might, you send them over there and get a radiograph of it. You look at it within 30 minutes. If you need an INR before you start doing surgery on someone, we can get you one in 30 minutes before the patient comes in. We run our own test. Try to do that in your private office. And our number one priority is the safety of staff, the facility, and offenders. How can you benefit? I know all of you out there saying, yeah, well, I'm donating. What do I get out of it? The work is quite interesting, for one. And you see pathology that is rarely seen in private practice. The work is interesting. It's not like private practice, which can be an intellectual wasteland at times. Steady employment. I counted them up, and I think there's been like 5 recessions in the last 20 years, or downturns. Patients don't come in to see them. I mean, dentistry is an optional service. So when we have a downturn, you take the hit. When you work for us, you have a downturn, you keep on working, and your pay stays the same. You work in an almost hospital-like practice. We have inpatient units in almost every facility. You need to put somebody in the bed upstairs in the infirmary, and you just work with the PA or the physician that's up there. You put them on IV antibiotics. You manage the patients along with the physician. You have an option that otherwise, the only way you can handle them is send them down to the oral surgeon. You know, they're the ones that have hospital privileges. That's what I said. It's interesting work. You have the benefits of health insurance, disability insurance, retirement pension. You don't pay any professional liability. The AG's office indemnifies you. No office overhead. You have patients from day one. And the knowledge that you're helping in underserved populations is very grateful for your hard work. And if you go to the right facilities, there's abatement of your student loans. I know you're coming out of school with a lot of indebtedness now. We have 2 programs that are available through working with us. At certain facilities, they give a point score for each facility, and some of them, like in Monroe, are low because, you know, right in the middle of everything. You go out to like Walla Walla or Coyote Ridge and with Tabasco, they have a higher score because they're not in the middle of things. They got to deal with people. So the National Health Service Corps Loan Repayment Program, or the Washington State Health Professionals Loan Repayment Program, will help you generously with your indebtedness. I can't say the amount that they're reimbursing right now, but the one through the National Health Service Corps, we're talking about over $100,000 in loan mitigation. So you work for 2 or 3 years, and then you can re-up, and each year you get a little bit more up to a certain level. And with that, we're back to Volkswagens. So I guess this is where I say that's all, folks, except for the questions. Anybody have any questions they'd like to ask? Yes?
Do you ever have patients with dental fears, and how do you accommodate them? Are you able to do like an oxide or oral sedation or anything like that?
I've had one patient that I've had to get Ativan to in 30 years. Most of them want to see you. The only reason I gave it to that guy, he come out of the military with PTSD. You started working on him, man, it's like he hopped on a horse. He just, he couldn't control himself. So I gave him some Ativan to get dose of it. He came right around. And actually, you have to work with him a little bit. Actually, it's pretty gratifying when you can get one of them to the point where they can handle such a thing. We do allow for you to use sedative agents, single sedative oral agents. Some of the dentists are real reluctant to. They think they're going to line up outside the door and everybody's want to get some Ativan before they get their dental treatment. I've never found that to be the case. It's just that there's sometimes when you need to be humane, medicate them down to the point where you can give them. They need them. Yes. Everybody's hungry? The next class.
I have a question.
Yes, sir.
How many instances of like the dentist in the future has their thing?
Zero.
Their-
Zero that I have had any knowledge of in 30 years. As I said, they're not gonna bite the hand that feeds them. You know, you're taking away their pain. Otherwise, then you sit over in their cell, and there's nobody to help them. Nobody at all. So when they're in a real jam, they come to see you, and you make life at least bearable for them. There's another one. Yes?
Two questions. So, first question is, do the inmates like oral hygiene habits improve while they're in prisons?
Yeah, just we give them hygiene instruction with the use of the hygienist. We try to get them cleaned up. A lot of times we have to do gross treatments when they come in, especially if they've been on the streets for a while. I haven't seen one of them yet that didn't accept the treatment and get with the program. They want to be better.
And then the other question is, what is the frequency of like fractured jaws or teeth? Like,
This has really
fights
gone
in
down
prison?
in the 30 years now. I started the Texas prison system, and it was like after the NBA playoffs, there was always somebody got a broken jaw. You know, this is somebody who went to the inmate store, bought a bunch of stuff, and he was running his own little store over here, started betting on it. He didn't pay off, so they tagged him. But I don't see that anymore. You know, it's extremely rare. I'm trying to think of the last one that we saw. And I actually can't at this point. It's probably been 7 or 8 years since the last one I saw. When you work for us, we teach you a lot about treatment of fractured jaws. It just comes with the program. Last in-service I gave with our oral surgeon was on putting arch bars and IMF on the teeth when you're stabilizing a fracture. Try to get a good union on it. How to replace them when they come in. They're in the inpatient unit upstairs. When they loosen wires on them, we put them back on. We know how to do that now. So yeah, your skills will improve. They're sort of targeted, but your skills in certain areas will improve dramatically. Your knowledge of medicine, pathology, pharmacology will improve far better in that environment than it will ever do in private practice. And you have another advantage. When they come to see you, they've got a health record. I get the whole health record. When you see a patient in your private practice, you are at their mercy. Whatever they tell you is all you know. So in this case, like I can look and see whether their liver's shot because the enzymes are elevated. I can tell things about how their clotting factors are working by the most recent INRs, for instance. We have a great advantage in that respect. And as far as safety is concerned, I was just going to make one comment here. You think you're not safe in prison. Have you ever thought about your dental office as a practitioner? What happens when somebody walks through the door with a gun and they want what's in your till? Is anybody watching your back? Who's there to bail you out? Nobody. We live in a strange world. Those things happen. In our world, there's somebody there to back in. So, yeah, it's not a bad gig.
Well,
Yes.
I just want to thank you for addressing the humanity of the people there. I think that's important, that the reasons that they've been there, sometimes it's for addiction, sometimes it's addiction or mental illness is not taken care of social services. And I think that's really important. I think the takeaway message is recognizing the humanity of the people that are in prison, as well as any community, as well as private practice. I mean, human beings everywhere have problems, but I think safety is a concern for people, so it's good to kind of get that out of the way and know that it is safe, and then they recognize the basic human needs of all people. So,
There are just many stories in the big city. There's all kinds of things that have happened. You see people that are in there that their father beat the devil out of them when they were kids. Had an old African gentleman that came in, and I was getting ready to give him a block, and I said, we'll put some topical on there. He said, don't worry about it, Doc. You got nothing on my dad. He used to beat me with a whip every time he came in drunk.
unfortunately, so we're gonna have to be out there.
So anyway,
But
you know,
unfortunately, that's common in all cultures.
It is.
It's